Hello, I'm Valerie Bush, Executive Director of Renaissance Journalism. Thank you for joining us today and welcome to our webinar, An Epidemic of Inequality, Uncovering the Impact of Racism on Health. Throughout the pandemic, communities of color in the Bay Area and in the US have suffered higher rates of infection and death, laying bare deeply rooted and systemic inequities that have long plagued our nation and healthcare system. Today, we invite journalists to join us and our guest experts as we examine and discuss how systemic racism and other related inequities and injustices, such as police brutality, hate violence, poverty, healthcare disparities, and overcrowded housing, lead to disproportionate illness, chronic suffering, and early death rates among low-income communities of color. We'll explore research into the links and often hidden relationship between structural injustices and biology and human health. And we will also discuss what is being done at the community level, structural level, and policy level to effectively address these inequities in medicine and in the healthcare system. To help us begin to delve into this critical topic and to provide ideas for reporting on it, we have invited two distinguished physicians and researchers from UCSF to join us in this conversation. Dr. Kirsten Bibbins-Domingo is an epidemiologist and physician. She's the inaugural Vice Dean for Population Health and Health Equity in the UCSF School of Medicine, and she is the chair of the UCSF Department of Epidemiology and Biostatistics. In 2006, Dr. Bibbins-Domingo co-founded the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General Hospital, a research center focused on healthcare disparities and the health of vulnerable populations. Dr. Rupa Marya is an associate professor of medicine at UCSF, where she practices and teaches internal medicine. Her research examines the health impacts of social systems from agriculture to policing. She is the co-founder of the Do No Harm Coalition, a collective of health workers committed to addressing disease through structural change. She is currently helping to set up a health clinic and farm at Standing Rock in order to decolonize medicine and food. With political economist Raj Patel, Dr. Marya is the co-author of Inflamed, Deep Medicine in the Anatomy of Injustice, to be published later this year. Our moderator for this webinar is Alexis Terrazas, an award-winning journalist who is the editor-in-chief of Tecolote, a bilingual Spanish-English newspaper that has served the Bay Area Latinx community since 1970. We'd like to acknowledge and thank the California Endowment for the support of Renaissance Journalism's Equity and Health Reporting Project and for today's webinar. Our format for today is as follows. Alexis will interview our guests for about an hour, and then he'll turn it over to the audience for questions at around 11. We ask that you write your questions into the Q&A panel of Zoom. This is also how you can let us know if you're having technical problems during the webinar. We are recording this webinar and will post it on Renaissance Journalism's website at a later date. Now it is my pleasure to welcome Dr. Kirsten Bibbins-Domingo, Dr. Rupa Marya, and Alexis Terrazas.
Thank you for that intro, Valerie. Much appreciated. And I would just like to start by thanking both of you, Dr. Kirsten Bibbins-Domingo and Dr. Rupa Marya, for joining us here today and to have this really important discussion. You know, as a journalist, I feel like it's only become like really recently where, you know, we're starting to wrap our minds around, you know, racism and the injustices that exist, you know, within healthcare or how it impacts our health. So, you know, we're just trying to do a better job, and hopefully we can, we can learn something from this conversation. And to kick things off, I'd like to pose a question to both of you. At what point in your career or medical education did you become aware that the medical field has an institutional racism problem? And as according to my screen, we'll start with Dr. Kirsten and then go with Dr. Rupa.
Wow, that's an intense question. It's sort of like if you're living in does the fish living in the fishbowl know that the water is wet, right? I think we grow up in this society, and what we are, the dialogue we're having is about how these factors are sort of deeply structural and ingrained in our society. medicine is no different. Medicine is a part, and in fact, medicine contributes. And I think that the journey probably for both of us in each of our ways has been how the ways in which we practice medicine, the ways in which we teach, the ways in which we conduct research, and the ways in which we engage in an institution that itself is a part of these practices evolves over time. And it's that constant sort of understanding what you're looking at, and then recognizing that everything that you're doing is a part of the thing that you're looking at. And I think that is the challenge. And probably each of us within our own domains, I'm primarily a researcher, attempt then with that understanding to try to make our work more meaningful, to try to illuminate and ideally dismantle the systems that we're talking about. And that's where the partnership with journalism is so important, because the illumination is at least as important, I think, in all of the work that we're all doing.
Yeah, I agree with you. So good to see you, Kristen. I just want to say, first of all, thank you for all the amazing work you've been doing. I don't get to run into you in the hallways at the hospital, and I have just really appreciated all the dedication and hard work you've been doing this year, especially, always, but this year. Thank you for holding it down. I agree. It's like, when did I first realize medicine was racist? Was it when I was a child at my pediatrics office and noticed the way that I was treated as a young brown kid? Was it when I was in medical school at Georgetown and noticed the way that different patients were treated? Was it, when I was a young attending or a trainee at UCSF? I feel like for myself, the consciousness evolved more deeply through, just as with journalism, through the stories of my patients and the communities that I serve. I have had the very good fortune of being a musician as well as a doctor, and very connected to communities in the Mission and San Francisco, throughout the Bay, through my music. And the act of being a musician is also a practice of learning, just like being a physician and a journalist, and to learning to stories and trying to understand what's going on. And so for me, it's been an evolving consciousness of how, as Kristen said, medicine is complicit in the structure of suffering towards Black, Brown, and Indigenous people in the society. And it is that way because it was part of the colonial project. It is part of how lands were colonized by Europe in the 15th, 16th, and 17th, 18th centuries till today. And so for myself, it's learning how my practices are then become involved in a system of violence, and how I can shift and change that, which is very challenging to do from within the system, but it must be done both from within and without the system. And I find a lot of parallels between journalism and medicine, because both of our jobs are so much hinged upon the testimony of others. That people are telling us how they're suffering and where they're suffering and when they're suffering and exactly why they're suffering. And we as doctors, when we write our history of present illness, when someone comes in to see us, we actually then, we often set the agenda and we decide what gets into the chart and what doesn't. And we then shift and change how the narrative is being understood through our lens, through a Western scientific lens, and not through the lens of the people actually experiencing the suffering, which we've been seeing here with COVID. So I think that can lead to what Miranda Fricker described as testimonial injustice, that we're not really hearing things clearly, that we're not organizing truth in the ways that would be reflective of patients' experiences, which is why so often people don't feel like their doctors really listen to them. But when we're starting to look at population health and what's happening to whole groups of people, that becomes actually, it can be a more catastrophic experience or participation of the medical system. So COVID, I think, has offered us a really a very powerful opportunity to question more deeply and to open our practices to bring in the things that we can learn from social movements and pedagogies that we learn from social movements that are transforming structural violence in other places in society, that we can incorporate that more into medicine. I'm sorry, that was a long answer, but I would say it's a constantly evolving piece of how I am a participant in a system that is violent. And I am in the role of probably the most oppressive figure, the physician. from a perspective of colonial medicine and what that has done to people around the world. And I'm also in a position of great privilege to be able to shift and change that dialogue.
Both of you touched a little bit on the, maybe how a patient would encounter racism. And I feel like, and just speaking from my own experience, I feel like when I was growing up, I kind of understood racism in the sense of like, something that happens to you, something that's incidental, maybe even accidental, but I'm really, I think we've come a long way in terms of like maybe it being accepted now that that racism is systemic in our society. But I did want to talk about, how does, in your opinions, how does racism and related, inequities such as poverty, overcrowded housing, hate, violence, police brutality impact somebody's, body, health, biology? Yeah, please, we'd love to if you have an answer for that.
Yeah, I think we can think about racism. One way to think about structural racism is that all of the other things that you said, and all of these other things are also patterned then by race, right? And racism. And so I think of these as creating environments that that actually put our lived experiences in very different contexts on the things that we know are health promoting, and the things that we know are harmful to health, right? And so, and the health promoting things we have to think of as really broad. So let's just think about the ways in which the neighborhoods that we live in are all really governed by both historical and contemporary redlining, right? That means that it's not just that means that all of the other things that we know from research are related to health also pattern in that same way: educational opportunities, job opportunities, where health clinics are. And so, so you can see that the roots of this redlining, rooted in structural racism, then determines all of these other things that also have a direct influence on health. The types of housing in a particular area, the types of jobs, all of those things. Those are I think of as like the health promoting things that don't exist then, are not patterned equally across the spaces we live in. If we then look at health harming things, we also know the accessibility to healthy foods, the accessibility to protect us from things that would harm us in environments, environmental toxins, other things related to that. So that's a very simple way in which we start out. And when you look at COVID and the pandemic, the map of the pandemic is a map of that very inequality. It is a map of historical redlining. It is the same map of the investments in jobs and housing. It is an education. It is a map that also shows you all of the other things that relate to poor health in those communities, in terms of environmental exposures and accessibility to the types of things that that are important for individual health. And so I think the pandemic just accelerates all of our understanding of that, because it's just so crystal clear how it all comes together. But there are a lot of ways to think about it. And I think the key in understanding sort of the complexities, that I think for a long time we understood medicine only through the perspective of health care, without understanding the broader context. But as soon as you understand the broader context, you realize that all of the inequities that shape the broader context then by definition shape health.
Yes, and I would say that this is the subject, not just the racism, but all of the isms that came with colonial cosmologies that structured our societies along gradients of power, where white cis hetero males have certain privileges that others don't have, where people of certain abilities have privileges that others don't have. So the book that we just finished, which is called Inflamed, Deep Medicine and the Anatomy of Injustice, looks exactly at how these gradients of power become translated into our bodies and into the processes of our cells. And what we see is a patterned, stereotyped response of the body to with inflammation, with an activated inflammatory immune response. And what we are learning is that most of the diseases that we treat at, UCSF and the hospital, most of the big killers of modern industrialized societies, the heart disease, the chronic obstructive pulmonary disease, the diabetes, the Alzheimer's, the depression and suicide. These things are all diseases where inflammation plays a part in the onset and progression of the disease, the expression of the disease. And when people are revved up in a state of chronic stress, when they are suffering from chronic trauma, you mentioned police killings. If there's been a police killing in your neighborhood, if that reverberates out into the community around, people are affected. PTSD, even stories of needing to be prepared for police violence have been shown to impact the telomeres of cells of Black men who grow up hearing those stories. And the telomeres of our cells have been associated with the life cycle of those cells. And when cells are shortened, their life cycle is shortened through toxic exposures, whether those are toxic environmental exposures or toxic exposures through stress and trauma. Those cells are more likely to enter a phenotype or an expression of a hyperinflammatory state. And we are now looking at how trauma and that intersection between trauma, inflammation, and this hyper inflammatory state are related to all of these diseases that we're treating and that are overexpressed in Black, Brown, and Indigenous communities. And COVID has been interesting because, as Kirsten said, it's a map. I feel like COVID exposes this architecture of injustice that our society is built upon. And when I say a colonial cosmology, I say a cosmology that is used to separate us from the relationships to each other that kept our lives vital and healthy. And that means across tribes and families and races, our relationships to the web of life that keep us totally vital and healthy. And that goes to what Kirsten was saying with access to healthy food. That's food that's been grown on rich microbial soil, not those that have been blasted by chemical warfare of the modern industrial agriculture. So when we have been separated from those things, in order to continue an economic system that requires desperation on the part of the working middle class, which is predominantly, if you look at the essential workers, most of them are Black and brown, and most of the undocumented folks here in California are essential workers as well. I think it was up to 80%. So that desperation is created by a society that will structure you along these power axes. And when you are that desperate, you are willing to sell your labor at, whatever cost. So if we want to look at the real roots of why we have these structures, we have to go back to, 1619. We have to go back to 1492. And when you're talking about, what is the effect on, in the medical situation, I'll never forget a chilling story. There's so many stories of the witnessing and experiencing racism in the medical system. But I was called by California Native people out to Standing Rock to offer medical assistance as the police were becoming increasingly violent to the grandmothers and the youth who were standing for the right to protect their water from having a petroleum pipeline put through it, the Dakota Access Pipeline. And as the police were violating, like just shooting these sponge grenades into the faces and chests and groins of young, bare-chested, youth who were praying in the water, this young man, in his late teens, was pulled out of the water, and he had a huge contusion, like a bruise on his chest. And in front of my eyes, he coughed up a cup, like a cup of dark red blood. And I've known from the reading about what I was going to be exposed to before I went out there, that a close contact, a grenade like that, a rubber bullet shot into someone's chest could lead to pulmonary artery rupture, could lead to exsanguination and death. So I told this young Native young man, I was there with the Cherokee trauma surgeon. It was just the two of us in this camp with, 12,000 people. I said, we got to get you out of here to the nearest trauma center. And the nearest trauma center was 40 minutes away. And I was like, well, we can't call 911 because those are the people shooting the rubber bullets at us. So let's get you as quickly as we can to the trauma center. And he said, I would rather sit here and die with you guys than go to that trauma center, because I know when I show up there, they're going to let me die anyway. And then I'm going to die around a bunch of racists. I'd rather sit here and die with you. And to us, to hear a young man say that broke my heart, to realize that their encounters with the medical system in North Dakota were defined by racism, were defined by the fact that their lives, their Indigenous lives, did not matter. And the reality of the US project is that Indigenous lives don't matter. This country was founded on genocide and land theft. And so we have to be conscious of that, because it will inform how our patients interact. You know, when we're wearing the white coat, when we're in these situations, these are forces and stories that are much greater than anything that a single person can reverse. Like we have to start reckoning with them together as a society. And so, it completely affects our bodies, and it's affecting them in a patterned way. And COVID is almost like a testing of the system. And it shows exactly how exposed you are to inflammatory stimuli. And those inflammatory stimuli are racism, they are the housing inequities, they are the redlining, they are the exposure to environmental pollutants that people are forced to, the exposure to wildfire that our farm working brothers and sisters have been forced to be exposed to. And so it really is a great moment for us to question, do we want a society based on manufactured desperation of people so that they are forced to sell their labor? Or do we want a society that is created and engineered through care, so that we are working knowing that our loved ones are protected, our families are protected, our health is protected, our water is protected, and that we can do our work with dignity and joy, not out of desperation. So that's the long answer to that question.
No, thank you for that, both of you. We do want to get into COVID, but right before that, and this is actually, I think COVID is woven into this next question, a big story, or I think something, a story that many newsrooms in the Bay Area have followed for a very long time here, housing insecurity, right? And the eviction crisis. How do you feel? I mean, and, feel free to, I'm sure COVID has a lot to add to this question too, but how does housing insecurity, the eviction crisis, substandard housing result in these health disparities? You already touched on a little bit about that, but I think a lot of times we have maybe we used to have a tendency of thinking housing is separate from health, but I think there's obviously very, very connected. So please.
Right. So let's we've talked a lot about appropriately so about the negative. Let me say one thing that I have appreciated during the pandemic is that it helps people to see much more clearly the connections. And let me say some positive things that come out of this. So even the way we finance health care and public health is separate from the way we finance the things that we know influence health, right? So even within city and state governments, public health sits in one budget, one pot of money, and housing sits in a complete other pot of money. So if you say, as we did, I practiced at San Francisco General, the first weeks of the pandemic, we were trying to understand how we were going to get people to isolate or quarantine if they were positive, if they were positive, they have somebody else who had tested positive, but we couldn't figure out exactly how to do that because all of that involves the pots of money and the way we distribute other things, right? The way people have access to housing. I think that some of the positive things in the pandemic have been things like the Project Room Key, have been things like looking at supportive housing and looking at the evidence in that, and the investments that have been made in that have been positive. I think that the hope of the pandemic is to think of those in more sustainable ways, because ultimately the problem in the pandemic has only just made it so clear about how the ways in which all of these are interlinked. So if you look that we think in many of our poor communities in California that exposure to the virus begins with essential work, and people who can't work from home, who are exposed in their jobs, who don't have the positions within their jobs, don't have the types of workplace that have those protections built into them, and then come home to environments that they are then exposing the people that they live with. If you look, the New York Times early on did this map in the Bay Area, showing where we have a crisis of affordable housing, showing the map of people where there's more than one person to a room in a house. That map overlays exactly on the map of where the highest rates of coronavirus transmission are. So you cannot separate essential work from where people who are doing that essential frontline low wage work are living, right? And you cannot separate that from the fact that I, as a physician, can say all I want to about isolating and quarantining. I can say exactly what the CDC recommendations say, but if someone cannot do that because of where they live, then it becomes completely impossible. And I think that we have to think through this, not just of how we do recognize that. I think the crisis allows us to recognize the interplay, but the solutions, because the fundamental problem is structural, not the pandemic, it's the structural inequities that existed before the pandemic. It means that the solutions cannot be just temporizing solutions. They have to be the ways in which we know some things actually have worked. That how do we then seeing that connection, seeing that those things work, how do we think about developing those into more sustainable solutions for health in our communities, but also sustainable solutions that ultimately help to dismantle the very inequities that are at the root. So that's both the hope and then the realities of what's on the ground in the pandemic.
Yeah, I have a very strong feeling about what's happened with our unhoused community members during the pandemic. I feel like it's been horrific to watch the thousands of people remain on the streets of San Francisco. I feel like the moves to warehouse people when we know that the virus, several of us were wearing N95s March of last year because this virus was acting like something that was airborne. So there's been the crisis, I feel, is not a crisis of housing, it's a crisis of greed, it's a crisis of distribution. For example, and I look back to history to help me understand what I'm seeing today. In the turn of the century, the last century, in the 1800s, late 1800s, there was a unbelievable famine that struck Africa and Asia because of patterns of the El Nino weather cycles and crop failures. And tens of millions of people died. There's a great book about it called The Late Victorian Holocaust. If you ever want to do some reading, it's a very thick read, but it's illuminating. And the tens of millions of people who died didn't die because there wasn't any food, because hundreds of thousands of pounds of grain were exported to Britain. It was part of the colonial structure and arrangement, so that there was a manufactured scarcity amongst the people who were desperately in need, to the point that tens of millions of Africans and Indian, Southeast Asians died because of the colonial distribution of resources. So now we're in San Francisco, we have a Texodus, we have all these empty buildings, we have, people have moved out of the city, we see all these new things, and still there are thousands of people that are left languishing in the streets. So is this a failure of structures, a failure of imagination, a failure of humanity? I see it as a failure of all of those things, because there are ways we could move to bring more people into housing and focus our energy and finances on providing people the services they need. The political will is not there. And that is what is deeply distressing to me. And why it is deeply distressing is because, just on a personal note, I have been forced to discharge people to the streets in the middle of a pandemic, people who are sick. So when someone's well enough to leave the hospital, it doesn't mean they're perfectly healthy and good to go. It means they're not going to die, so you can send them out. Like their acute issue has been, you've kind of held it together and they're off to go. That means someone with cancer is back out on the streets. It means someone with chronic obstructive pulmonary disease is going to go back on the streets. Someone who needs dialysis is going to go back on the streets. And so that the moral violence that has been done on our healthcare workers, and I say this because one of my colleagues discharged someone in the midst of the pandemic to the streets, unhoused. He ended up dying on the corner like 2 days later, dying on a street corner. That doctor did not get out of bed for 3 days. She was heartbroken. And that is a young doctor who has already suffered her own medical issues from burnout. So these kinds of things actually cause distress in our system as well. It's not, of course, we're in a position of privilege. I go home, I have my family, I have my home to live in. But the moral distress that the city has forced us to endure by their failure to actually do widespread protection of people, not just during the pandemic, but then the added catastrophe of the worst AQI we've seen in the Bay Area for 3 consecutive weeks. So now people's lungs were getting inflamed, breathing that air outside. So I think that it to me, really puts the task on us as medical providers and also you as journalists to tell the story really properly, to get to the point of shock again, to go, oh my God, this is happening. This is really happening. We have decided that these lives don't actually matter, because if they actually mattered, we would be providing them not with a tent on a parking lot square grid. We would be providing them with all these empty rooms that are sitting here in San Francisco. There's plenty of room. There's plenty of grain. It's not being distributed properly. So that's the hallmark and violence of capitalism and a society that's so enamored of profit that we are going to let people, and business interests, that we're going to let people languish and die and suffer like that. And so that, to me, I know that's, it's not a rosy picture. I'm grateful to see that Project Roomkey has come about and that people are starting to see more movements in tiny incremental ways in public policy, but things need to be way, way faster, way more and less conciliatory to these processes that are actually causing the violence. And this leads me to just one last thing I want to say is, because we do a lot of research in medicine. We like to research things and look at disparities and name disparities. And what I've come to through COVID and George Floyd and, in this last year of awakening, is that naming the disparities is no longer enough. If we are naming the disparities without naming the structures that need to come down and be restructured ASAP, we are actually just a part of the problem. As medical, we know we're part of the problem, but we're an even more insidious and violent part of that problem, because we need to get down to, all right, here are the disparities, here are the solutions. This is my prescription as a doctor. Virchow, who's one of our heroes in medicine, the father of pathology, he identified a lot of different things in the body. We have nodes named after him. He was a young doctor in a time of great revolution in Europe in the springtime of nationalities in 1848. And he was fighting for the sovereignty and dignity of communities that were being oppressed through German imperialism, through the same colonial structures I'm discussing right now. And he went to go study an outbreak of typhus in Silesia, what is now modern Czechia in Poland. And when he came back to deliver his report, he's like, the outbreak in typhus could be cured by better roads, better education, allowing people to learn their native language, building worker-owned co-ops, developing better systems of agriculture, separating the church and state, and taxing the rich and giving the money to these social systems. So that was the doctor's prescription, because he could see it's not about the bacteria. It's about the structures around the bacteria that are driving the response. And the same thing with COVID. It's not about the virus. It's about, where does COVID thrive? It thrives in spaces of incarceration. People who are incarcerated in their labor, Amazon warehouses, mink that are incarcerated for their fur, 17 million in Denmark, our farm workers who are incarcerated in the worst housing. It's an unbelievably cruel system of agriculture here in California. Our elders who are incarcerated in nursing homes. Are people who are incarcerated in overcrowded housing. So it's these places where people are being socially forced into close encounters like Kirsten's talking about, when there's plenty of space and plenty of housing. So it's a good time to get out of the scarcity mindset so that we can adapt structures now for when the next pandemic comes or when the next variant comes. Let's get those structures in place now so that our society can be more resilient.
Thank you for that. I did want to weave in a question specifically. I feel like a lot of our communities have been really hurting, especially with this recent wave of violence against our Asian American and Pacific Islander communities. But I wanted to see, what maybe you two or other doctors think the impact on this violence will be to members of our Asian American and PI communities, like their health, mental health, and is there any research being done, perhaps at UCSF or elsewhere, on the longstanding impact of this recent wave of violence?
Yeah, so I think that that Rupa has already alluded to some of the pathways that we know that a traumatizing event like a police killing, like the mass murder in Atlanta, like the violence we've seen on our streets in San Francisco and in the Bay Area, that those have effects on the people who identify with what is happening in with that type of violence. We see it in terms of lots of inflammatory markers and blood pressures and things that you can physiologically measure changes. It's quite striking actually how consistent it is over time to that these events don't just affect obviously the individual who is the target, but they really do affect not just the immediate community, but those people who understand that the nature of the attack as an attack on themselves and their communities, and it has physiologic effects on the individual. There's also the broader, obviously, mental health effects. But I'll tell you the thing that has me concerned, in addition to those things, is also the very, very real ways in which right now we are very concerned that it is leading people, older members of our Asian communities, not to come out for vaccines, for example, right? Not to engage in other things that we know during this time of pandemic to be particularly crucial for aspects of their health during the pandemic. And so those are the ways in which all of those things together really end up playing a role in health. And then when you add in the additional aspects of, as Rupa alluded to, that if hospitals, if medical care is not a system that you believe you are going to be treated with that type of respect, then those become points of threat as well. And so the impact of these are really quite multi-layered. They affect the health of individuals physiologically. They affect patterns of behavior within the community to adjust to threats that are there. And the ways in which we adjust to threats have an impact both on our physiology, but also on other aspects of the things that we would ideally love everyone to be able to do that relate to health promoting and health preserving activities. And that's the ways in which I worry this is going to be, that there will be immediate and long-term harm, and it will ripple way beyond sort of that immediate, like, let's protect people from the violence itself.
Thank you, Kristen. That was great. I'm going to add the rosy colored moment now here, in that while we do know that experiences of racism, traumatic events like this do register in our bodies, there are things that we can do that can help mitigate that. And one of those mitigating forces is justice through our system, so that when there is a racist event that happens, that we name it as a racist event, that we describe it very clearly, and that communities come together. When communities come together to provide security and mutual aid, to provide neighborhood watch, to start getting involved and empowered to take care of our Asian brothers and sisters, or our Black brothers and sisters, whoever's being targeted, that we make that those practices of building community and showing up for each other, and getting justice have actually been shown to lower inflammatory markers. And so you can actually, we have the medicines we need in us, in our communities, to provide an ameliorating effect. And it must be both structural and also interpersonal. And I think that those things actually go a really long way. And I'm excited to see that solidarity growing between different groups who understand that this violence, the white supremacist violence, that will pit different groups against each other, is something that's eroding the fabric of our society. And folks who are identifying this, when you start to hear people who identify as white identifying this as a problem, then you start to see a society wanting to shift and move past these narratives into ones that can build greater networks and foundations and protection of each other. So I think that there's a lot of great work happening right now to on the community level to protect our groups, but then also we have to force our governing structures to take these matters extremely seriously, and to have a zero tolerance policy for them and to name them appropriately, that these are acts of terror that are meant to intimidate and frighten our community members.
I have a COVID specific question, and both of you have really talked about, how much COVID has revealed about us and our society, its shortcomings, right? But I really am interested, we're at, as a journalist, I remember reporting really early on, and after the data came out on how it was disproportionately impacting certain groups, it wasn't necessarily surprising to us, but the data was there to back it up. And we got to realize, okay, yeah, all these different factors play into it. But now with the vaccine rollout, how do you see that playing out? Like, how do all of the things that contributed to the disproportionate impact that COVID had on our communities, how do you see that structure impacting the vaccine rollout? And have you seen any successful grassroots kind of communities coming together to assist in these, either testing or rollouts that maybe we can implement going further when we build a better society?
Yeah, so I have a lot of opinions on this. It is very clear that there are successful ways to make sure that our communities that have been the most affected during the pandemic actually get the vaccines in the ways that it is required. And those almost to a one involve community partnerships, hyper-local efforts to really both make sure that a vaccine is available, that information is available, that the information is coming from community members. And ideally, sometimes the vaccination is happening locally, but sometimes it is that these types of partnerships are actually the ways in which we can link individuals to these other sites that are doing vaccination. So lots of different types of ways. And one of the things that I'm proud of at UCSF is that we have been involved in many of these partnerships. These are partnerships that developed almost to a one before the pandemic, because partnerships are about trust. These are partnerships that I think were really sustained during the pandemic, because for a long time throughout the pandemic, testing was not available to many of the communities in the ways that we would have expected for the level of transmission that was happening in many communities. And now during the time when we're trying to vaccinate, we're trying to do that as well. What I would love to communicate about the vaccinations is the way, and what I am always distressed about, and now that I get to speak to journalists, I want to tell you what I wish you would also report on. I love that you can see in almost every paper this sort of pattern on the epidemic reporting, which is you do a whole week of a bunch of stuff, and then you do the requisite equity story, right? Which is this community and a whole bunch happened, and it's really terrible and whatever. The entire story of the pandemic is about the equity story. Our failure to prevent 3 surges have to do with our failure to understand where the virus was and to put resources where the virus was. So that is true. So the equity story is not the human interest on day 5 of the week story. It is the story that everyone should be asking. If we're really trying to prevent the next surge, where should you put your public health dollars? Where should you put your investment to prevent the virus from surging? And that it requires saying, not it's available to everyone. It requires saying we have to get testing, and in this case, vaccines, to where we know the virus is going to surge. And my big concern right now in California, we've had a reasonably successful vaccination rollout. We're sort of middle of the pack compared to the other states, but we are at the bottom of the pack. We are the bottom 10% of states in terms of our equity rollout. So that means we are already seeing around the country resurgence, the next surge, the 4th surge. It is almost inevitable that that is going to happen in California. I hate to be a doomsday predictor, but right now, across the Central Valley, that is where we are under vaccinating. In Imperial County, that has been hardest hit throughout the pandemic, we are under vaccinating. And in the Bay Area, in the communities that have been hardest hit, that is where the lowest rates of vaccinations have been. And so when we look at variants, when we look at surge around the country, it is almost predictably going to happen in exactly the same way. And the concern I have with the vaccination story is that, unfortunately, while I had hoped throughout the pandemic that people would see the link between equity focus and effectiveness focused, you can't be effective unless you're focused on the communities that are most affected, because that impacts all of us, is now the vaccines are wonderful public health tools, but we interpret them as we protect ourselves individually. And that is what is going to not lead us to really understand the true dynamics here. And so my prediction is the Bay Area and California will not reach that vaunted herd immunity that we all hope for, because we're going to continually cycle through these mini surges that won't affect all of us, just like the pandemic hasn't affected all of us. Will continue to disproportionately affect these communities, but we're also not going to do what we need to do to actually get viral transmission low enough that we can actually open up in the ways that we would really like to, because we haven't focused where we need to focus our attention.
Oh man, that was perfect. Thank you, Kirsten. And I think that same story goes with the world. It's a global phenomenon. So the global South, the vaccine distribution right now that we're seeing, we're going to keep incubating these viral variants around the world that are going to come back and bite us in the butt, which is what's happening right now. And it's going to keep happening. And this thing is going to keep cycling until we learn our lesson that you have to start focusing where the suffering is happening and ameliorate that suffering. And if that means radically changing the structure of agriculture in California, let's do it. It's time. Climate change is here. We need to take care of our soils and take care of our people. This is the time to do it. There's no better time to do it. We need to be offering our folks in the fields relief from deportation so they don't feel afraid to go and engage the public health services that Kirsten's mentioning. It does no good if you offer vaccines if people feel like ICE is going to come and take them away. And so the structures around the public health availability, even if we had all the vaccinations in the world, a lot of that trust is not there because of these racist phenomenon. And so people will remain, to the side and afraid and keep spreading the virus. So in order to really address this pandemic, we actually need to go whole hog in and not be afraid to adjust our structures so that we can ameliorate, where the abscesses are, we go in there and we open that up. Unfortunately, as Kirsten's talking about, people are thinking about their individual selves, like I want to go on vacation, I need my vaccine passport. Whereas, someone who's picking our grapes just needs to get money to feed their children. And they're so desperate that get a vaccine for that person will affect an entire community of people and will keep the whole system safe. So once we start to understand, and I feel like this is why COVID has been a remarkable moment for us to understand our dependency upon each other and our dependency upon the web of life at this critical minute where climate change and climate catastrophes are just going to keep hitting us harder and harder. And I see COVID as one of these climate catastrophes. It gives us a moment to just check in with where the system is right now. The system is highly dysfunctional. The system is not resilient. The system requires food being imported and exported from way too far away. The system does not allow people to be sheltered when the air is bad. The system does not allow for the people who grow our food to be protected so that we can ensure we have food. Our supply chain gets blocked by a ship 10,000 kilometers away, stuck in a canal. Like, this is insanity. If you think about, what this disease has exposed for all of us, is how vulnerable we actually all are if we're not taking care of everybody. And so I've been shocked. The viral stories, the vaccination stories that have shocked me are the people who are jumping in line to get a vaccine when essential workers have been forced to be exposed. And that to me, that just breaks my heart, because I would think that, after seeing all this data and all the, stories about equity and who's getting impacted, you just think people would have that decency to go, okay, everybody had a hard time, you all go get vaccinated, I can wait my turn. But that's not the case. And that's, part of the cultural structure that's the story and myth that needs to be busted open.
Speaking of stories and myths that need to be busted, I did have a question about the scarcity narrative, right? This narrative that suggests that there aren't enough resources for everybody. How do journalists in particular reinforce this myth in their coverage, and how can we break that pattern?
I haven't given this much thought. That's a super good question, though. I think that journalists. I'm not saying all of you, and I'm sure not you, Alexis, but I think that there is a way in which journalists like to create a binary, dichotomous, tension-filled story, which makes you believe that it's a zero-sum game. It's either this or this happens, right? It's either we have vaccines roll out quickly or we pay attention to equity, and don't say, well, and don't ask each of those, because I'm interviewed now for stories all the time, and don't ask each of those speakers to ask the other question. Well, why can't we have both? Well, what would it mean to think in a different way about this problem? And I think, and that is the way the stories end up getting written, is that, it is this, or it might be this, because I want an alternative viewpoint. And in the end, we should challenge both sides to say, well, what if we were different? What could you change? What would make it different? Because then you would allow us to think more creatively about the solutions to the problem, as opposed to the alternative viewpoints.
That's a great answer, Kristen. And I also feel like, the journalists set the agenda by defining how broad or narrow we will understand the problem and the possible solutions. And, there is so much wealth in the Bay Area. And it's hoarded right now. There's so much ability. Like, California is the only state that has a huge oil production that doesn't have an oil severance tax. Let's tax those oil companies and get that money into our public health funds. Let's create, after the success of the sugary drinks tax that brought in inordinate revenue for San Francisco, Oakland, Berkeley, let's get one on the state ballot. Let's start taxing those industries that are making our people sick, so that we have all the infrastructure and support we need to get single payer going in California, so that nobody is left out of the shelter, that nobody is left without healthcare, that nobody goes bankrupt going to a doctor, that nobody has co-pays and all this insanity from private healthcare insurance. So I think that the myth of scarcity is one that keeps the desperation factor going. It keeps the engine of our economy going. So you have to have journalists who are willing to challenge that engine of our economy, that concept of manufactured desperation, and say, what happens if we cancel student debt? What happens to our youth? What happens if we get single payer in the United States? What happens to these things? And start exploring that more broadly. The money's there. It's just, again, just like the rooms in San Francisco are sitting there vacant, waiting for people while thousands of people are on the street. That's not a problem of scarcity. That's a problem. It's a lack of creativity. It's a lack of humanity. And it's a lack of political will. And so journalists can help drive social change by being bold in their inquiry and engaging in practices that cultivate their own imaginations about what is possible. But Kirsten just said that, we can't be thinking about this problem and solving in the same ways. We have to have new ways of thinking of these problems because they are hopelessly interconnected. And we can't hope to tweak one little thing here and expect this thing not to fall apart. The whole thing needs to be brought into focus and reassessed from a health-based perspective, because all the challenges that are coming to us in the next 50 years are all going to threaten our health. The wildfires, the heat, the drought, our reservoirs this morning in California are 50% capacity. Where's 80% of that water going to go in California? It's going to go to industrial agriculture. Why? Why are we using agricultural processes that are going to suck all the water out so that when the fires are there, they're just going to rip through our state? This is a time to start looking extremely holistically at these things, because in the end, I can give people an albuterol inhaler for their reactive airways after they've been exposed to, wildfire, but I can't stop them from dying of the heart attack that wildfire smoke causes. And I can't stop the wildfires unless I start getting involved in where's our water scarcity actually coming from? Again, that water scarcity, there's plenty of water in California, it's being misused. So it's a great time to think radically, and by that I mean from the root cause of the problem, imaginatively, and outside the box, because these problems that are coming in the next 50 years are going to really challenge us.
I think, let me just also say, one of the things I've loved during the pandemic is actually working more closely with especially local journalists, because so I'm a researcher, so I approach the pandemic from trying to understand where the data is and what the data is telling me about policies, whereas journalists tend to understand what the political landscape is, what the community landscape is, what the issues are more locally that I'm sometimes not as attuned to. And I think journalists are outstanding at, of course, telling the stories. They are outstanding at finding the tension in a political narrative that then has a public health impact. And I think I've really just appreciated the different tools that each of us use in our work, and when there's an opportunity to think about tools together to actually shine a light on what's going on. I had a great conversation with a journalist. I've had several great conversations with journalists in the last 2 weeks about this very thing, and really appreciative of the ways in which we journalists obviously have the ability to tell the story, but to also then think about how they can craft the things that other people bring to that are relevant to the story in a way that can really magnify its impact. So.
Oh, thank you for both of those really well thought out answers. And you are absolutely correct in that journalists do have that tendency to try to simplify things, and that'll lead to the creation of maybe like a narrative that they want to go with, and that inevitably creates blind spots. So you are both correct in all of those. I've experienced that in every single newsroom I've stepped into. But we're at the hour, so I do want to switch gears to some of the questions that we have received through the Q&A. And one of the ones that came up are actually, speaking of journalists, so what are other mistakes that journalists are making in our coverage of like health inequities?
I would say, like doctors who come in with a kind of top-down understanding of disease, not giving as much focus to community voices and perspectives about why the pandemic is happening the way it is, how people are getting sick, what they're experiencing, and what their proposed solutions are. Because, you know, just like most patients, they'll tell you why they're sick and how they got sick. If you just really listen, the stories that people tell are very illuminating. And while experts are, you know, helpful to get a broad sense of patterns, it's not the same as working with community groups on the ground and just people who know their community and the mechanics of how things are working. I do agree with Kirsten that some of the greatest partnerships I've seen come out of the pandemic have been like with Alicia Fernandez both in East Oakland and Fruitvale and in the Mission District. And Kim Rhodes has done some great work as well with Bayview Hunters Point community and East Oakland community. But understanding, you know, who the community groups you are talking to and how they see what the problem is and how they see the solutions. I would love to see more of that in reporting, because while it may be specific to one community, it is probably translatable or something that others could find common, because these structures are recreated all throughout our country. They're not unique. And so I think listening more to people's stories and letting them set the agenda and letting them dictate the narrative more.
Yeah, I think that you know, journalism suffers from the same problem we have in public policy, the same problem we have in the way we construct academic institutions, is that, you know, you have your beat that you're covering and that you're tending to cover that story within that beat. And so if you are a journalist who covers the medical discoveries or the health or whatever that's your reporting, you are going to you're going to do a lot of stories which are about cool biological discoveries, about cool things that a lot of cool things in health and medicine and science. I think the challenge for understanding inequities in health is that it makes you go outside of that narrow thing. You have to understand about how the social is the biological is the social, that they're interrelated, that it isn't this simplistic narrative is hardly ever the fact. And the danger that journalists do when they cover health disparities oftentimes is that it becomes there's a tendency for in our academic institutions to make these be biologically determined. So if you look at all of the early narrative in the pandemic, this was all about vitamin D, and it was all about something else that was somehow biologically why we were seeing more deaths in these communities. And I think it's natural because, you know, I assume reporters have the group that they usually go to. If you're normally reporting all about medicine and whatever, you have the people you usually go to. Those are not necessarily the same people who can tell you how to think in more multidimensional ways about why we see these patterns in this way. And that requires more work, but it is like what's necessary to cover these types of inequities, health inequities, in a reasonable way.
Yeah, and I would say, get my book. It comes out August 3rd. I spent a great amount of time during the pandemic sitting and researching and writing it with Raj Patel, who's a political ecologist and economist and food systems policy person. Because we go through a way of thinking through these problems. We go through each biological anatomical system and take our familiar understanding of it and make it strange along the way that Kirsten's talking, by bringing in intersecting histories and sociologies and narratives and understanding, so that, you know, when you're talking about a story in this moment, in this snapshot of right here today, that we actually understand all the forces and histories that come to bear on this moment that makes that body primed in the way that it is. It is a biological response, but it is not a biological fact. that it has to happen in this way. It's not predetermined. It is becoming determined by all of these forces around the body, which is what Virchow identified. One of the things Virchow also said, I'm a big fan of Virchow. I never thought I'd be such a fan of a 19th century German, but I am. He said, when you look at bacteria like the bacterium that causes tuberculosis, it's not TB that causes tuberculosis. It's not this mycobacterium. It's the way the body reacts to the TB that causes the disease. And in fact, you'll see various expressions of tuberculosis. Some people will get really sick with it. Some people will harbor it and carry it and sequester it. And our bodies have all these different expressions, same with COVID. So it's not the virus itself that's causing the distress that we're seeing, it's the body's reaction. And certain bodies have been primed through these structures of history and modern experiences of oppression to react in this way. And so it is imperative that journalists become conversant in understanding what all of those things are that create this exposure, how our bodies are being exposed. And so the book comes out on Farrar, Straus, and Giroux in the US. August 3rd, we're going to be doing a party with city lights. It'll be virtual, which is so sad because, oh my God, it took so long to write a book and now I get to do it virtually, but that's okay. We will be hosting a small gathering on a farm. We're working on a farm, working to get 38 acres back to the Ramaytush Ohlone people, the indigenous people of the San Francisco Peninsula, down the coast in San Mateo. And I think we'll be meeting there to celebrate the book release. But yeah, I think that reading people that are bringing together these analyses, following people like Kirsten on Twitter, because she often will bring together these analyses in certain ways. And there's lots of great Black and Brown and Indigenous health workers now who are pushing this narrative. So following those folks would be something I would recommend.
Thank you. And we have, I think, maybe one more question from the Q&A session. And both of you are researchers. And so the question is if you'd like to share maybe some of your recent work or research, and what are some of the findings that that you think journalists would find interesting, and for maybe some kind of the story ideas that you've already, or in the line of the story ideas that you proposed already.
Well, so in my day job, I'm a cardiovascular disease epidemiologist, and I'm interested in heart disease and inequitable distributions of who gets heart disease and its impact. But during COVID, the tools that we've been using are understanding who has died during the pandemic in California. So we have all of the death certificates from the state. We get them updated regularly. And we've been looking at deaths in California during the pandemic compared to all of the prior years. So that methodology is called excess mortality. How many more deaths did we have this year than you would have expected in California in the month of April, for example? And that we've now published a series of papers looking at describing the excess mortality across race and ethnicity, as we've talked about here today, and the high burden, particularly in our Latinx communities. Also, some things that are important to understand in that is how much this is about the risk for our immigrant communities, our immigrant Latinos, those who have less education and therefore are likely to be in the lowest paid jobs in the lowest income communities. And 2/3 of deaths in California are actually in people who don't have a high school education. And so you start to see what we frame as race and ethnicity appropriately for many reasons is really is really in the pandemic. The class story is really just quite striking, and especially when you look at education and race and ethnicity together, you see how protected some groups are. If you're white and you have a college degree, the pandemic is almost there's almost nothing happening in the pandemic in terms of excess mortality. We've done papers on the occupations. That's really where we showed that food and agricultural workers have the highest excess mortality in California. What we're really interested right now in is understanding other things that might have affected health during the pandemic. We're interested in overdoses because that has been an important story. We're interested in the fact that the excess mortality in California, as it has been throughout the country, only about 3/4 of the excess deaths are COVID confirmed deaths. The number of excess deaths during the pandemic is actually higher by an additional 25%. So what is that 25%? Is it undiagnosed COVID? Is it something else? And how does that differ by the patterns of inequities that we see? You'll start to see a lot of work that's going to come out in this area. And some people ask, well, why is it important to understand this retrospectively? The retrospectively also tells us the forces that exist that we have to understand prospectively, right? We imagine that, oh, it would be great and we actually know everything about the pandemic, now we can move on, but we don't. We have big gaps in our understanding that tell us what were the problems with who we tested? How big was the pandemic really in some types of institutions, in some types of counties, for some communities, and then where were the other things that happened during the pandemic that really affected all of our health that we might not have paid as much attention to because we had this whole coronavirus thing going on. So that's the type of work we're doing right now, and then and hope we'll be publishing on, I'm sure, in the next number of months.
So I am not a researcher. I do research when it's been commanded of me by community members, but I do not position myself as a researcher. And I'm learning. So the work that we're doing on the coast we are doing this project that we're calling Farming as Medicine. And so this phase of my life, I'm very interested in structural solutions and putting forth models of structural solutions that could be scaled not by going big, but by replicating small like a virus. And this one is a project where we are looking at when you bring Indigenous people back to sovereignty on their own land, and you hire farmers as land stewards, ecological stewards of the water and the soil, giving them salaries, solid salaries, and you liberate the food from the market economy so that the farmers are not then getting paid per pound of cilantro that they're growing. And then you give that liberated food to communities who are suffering the impact of COVID in San Francisco. We're working through TNDC, Tenderloin Neighborhood Development Corporation, and the American Indian Cultural District. You give away that food. What happens to the health of the Indigenous people? What happens to the health of the soil and the water? What happens to the health of the people receiving the food? So that's the kind of research that I'm looking at right now. And with the confluence of these forces that we're talking about, seeing that, solutions that can flip the system on its head, how can that then have impacts in climate justice, health justice, economic justice, racial justice, so that we're keeping all of these systems moving together and analyzing them together. So that's one of the, probably the next 5 years of my life will be taken up by that work. We actually slept the first night on the farm last night, and I rushed home to come here to do this, and we'll be starting to get that first field into production next weekend. So we're very, very excited.
Well, congratulations on that, and just a sincere thank you to both of you for joining us today. I did want to give a little plug, if that was okay. Dr. Kirsten, you could follow Dr. Kirsten at K Bibbins-Domingo on Twitter for her excellent analyses, and Dr. Rupa Marya at Dr. Rupa Marya, also on Twitter. And there, I think you have a lot of information about your upcoming book as well. So thank you again for joining us today, and for this really amazing conversation. I felt it was really, I think I speak for a lot of journalists when I say that I feel like we really need to hear these voices. So anyway, I want to toss it now back to Valerie Bush.
Thank you, Cole. Thank you. I want to thank all three of you for this thought-provoking and informative discussion. I also want to thank our audience for joining us and for your interest in covering this and other critical social justice and equity issues. This webinar will be archived on Renaissance Journalism's website at www.renjournalism.org. Have a wonderful rest of the day.